day, everyone, and welcome to the last CAEP National Grand Rounds of this very auspicious year. I want to thank CAEP for organizing these rounds and all of their work they've done for education and advocacy for the EN community. I'd actually like to start with some land acknowledgements, and I want to acknowledge with gratitude that I live and work in the unceded territorial homelands of the Musqueam, Squamish, and Tsleil-Waututh nations, and that we are all on traditional lands of different nations across the country. I'd like to now introduce our amazing speakers, and we'll start with Bruce Moore. Bruce is an emergency physician at the Whistler Healthcare Center, and he's been there for about 25 years and has lots of experience in trauma. It's a very unique place in that it's a diagnostic and treatment center with no backup supports in-house, but they see a lot of trauma and they have to resuscitate and transport. And in fact, they transport more traumas out of their site than any other site in BC. He's also a ski patrol doc and the physician for the Canadian Alpine Ski Team. So welcome, Bruce.
Thanks, Hazel.
And I also would like to welcome Sarah Giles, who is a remote and rural physician who's worked all over Canada and as well has done many tours and projects around the world with MSF and is presently in Kenora, I believe. Welcome, Sarah, staunch advocate for rural medicine. And then we have Chris Hicks, who is an emergency physician and trauma team leader at St. Mike's Hospital, which is a level 1 trauma center. He is a SIM and human factors guru and a education scientist, and welcome. I've heard him speak a number of times and he's quite brilliant, so thank you, happy to have you. And as well, Andrew Petrosoniak, he is also an emergency physician and trauma team leader at St. Mike's, as well a SIM lead and educator, and I believe you're the SIM lead at St. Mike's, and also has a master's in medical education with an interest in simulation and trauma. So welcome all. I'd like to just note conflict of interest, that there are none, and that the scientific committee has reviewed them, and there are no disclosures to note. And just to speak to our objectives, so I think what we really want to talk about is planning for major trauma resuscitations and what that might look like at your site, whether it's a small site or a large trauma center. It may look very different. And then applying principles of crisis resource management. And a lot of you are familiar with that term, but essentially it's effective teamwork in the skills required for effective teamwork in a crisis situation. And that can include planning and anticipating and knowing your resources, calling for help, role delegation, clear communication, all of those things that are needed for effective teamwork. And then just understanding and appreciating the differences in different resource settings. So in a major trauma center, there may be challenges with communication and leadership. You have many, many people in a room, perhaps with different specialists and competing priorities. You may be in a very rural, remote site where you're really limited by human resources and your equipment and your weather and transport delays. So just appreciating that. And with that, what's different about these rounds is that it's going to be a slightly different format, that this is going to be not a speaker kind of lecture based, but more of a discussion. It's going to be a case-based discussion. So, and actually I just have my first question, which is it common practice in rural departments without CT scan access to use fast exam to rule out abdominal and thoracic trauma? Not very sensitive except for pneumothorax. And I think we'll get to that as we go through this case. We can talk a little bit more about that as we know there are many, many sites that do not have CT scanning. So I think what we're going to do is start with a case that will be presented to a rural site. And so you're going to get a patch, and Sarah, you're going to get a call from EMS. And there is a 46-year-old male with an ATV rollover who has some obvious chest and pelvis injuries. And those are their initial vital signs at the scene. They're going to scoop and run, and they're going to try to be there in 10 minutes. So you can see a little confused, tachycardic, hypotensive, tachypneic. So ATV rollover is probably not unusual in some of the sites you've been at, Sarah. How would you think about preparing for this patient?
Yeah, thanks, Hazel. I would definitely say that ATVs, I call them all trauma vehicles. They are bread and butter, and this would not be an unusual presentation. When I think about a patient coming in who looks and sounds like they're sick, I kind of break it into P's, much like in intubation. I think about the people that I'm going to need. Often we have our diagnostic imaging tech off-site. So when I hear this patch coming through, I'm going to say, okay, these are the following people that we need. I need the diagnostic imaging tech. I need lab. Depending on where I am, I may have the very rare privilege of having RT or anesthesia. I may have gen surge. Those people are probably all off-site and will take 10 to 20 minutes to get to me. So I'm going to call them first off. And then I'm going to call the nursing supervisor to help me get everything sorted. In one of the places I work, the nursing supervisor has the job of clearing the helipad to make sure there is no bear there and that none of the garbage that the bear eats from the dumpster is loose and flying. I think of the places. So this person may need intubation. So I'm going to want to use one of our negative pressure rooms, often our only negative pressure room. I want the equipment in place. So our ultrasound, our rapid infuser, if we have one, the video laryngoscope, and the airway equipment. That all needs to be moved to one place. We don't have duplicates of these things. I think of pee as in I need to pee. I will pee and try to slam down some water because often I could be with these patients for the next 4 hours and it's much easier to think on an empty bladder. I'll think about pre-drawing up certain medications. Like there's a high chance I'm going to want some TXA, some ketamine, and having a little phenylephrine in the pocket never hurt. And then finally, PPE for me and for everyone.
That's excellent. Thanks, Sarah. Bruce, do you have anything to add from your perspective in terms of preparation? That was pretty thorough.
It was, yeah. Thanks, Sarah. We have a lot of the same issues as you, helipads and stuff, and yeah, bears, coyotes and things. But yeah, in addition to those things, I'd also be thinking about or asking the EHS crew if they had initiated auto launch, but only because, particular to BC, perhaps, if they've initiated auto launch, it means that there'll be transport coming up by road or air to us, to the Whistler Healthcare Center, before even we'll receive the patient. And that's just really important because this sounds like the kind of patient that's we're gonna try and stabilize and then get down to Vancouver as soon as possible by land or air. So I'd ask them if they had a name, just in case it happens to be a patient that we have a record on, so we could look up some stuff. Beyond that, in terms of the same things in terms of site prep and calling in people, I have to, depending on the hour of the day or night, I have to call in lab and x-ray and an extra nurse or an extra doctor who are all on call. Preparing the trauma room, as you've said, negative pressure, getting meds. The nurses really love to hear what possible meds you might want to use so that they can pre-draw them up and have them ready, because it's a task that takes a little bit of time. And then getting things out, like letting x-ray know that I might need some portable x-rays. They're going to have to come in as well, but they've got to get the machines warmed up. And yeah, things like this sounds like it might need our trauma room doesn't always necessarily have a sheet on the trauma bed. So we're going to get the slider board out and get a sheet on there in case it's a pelvic trauma that needs stabilization. So that's basically it, getting the room ready. And then if there's time, assigning roles to the people that I have called in. And it could be anywhere from just me and a nurse to myself and another doctor and, 3 other nurses. And so assigning roles so they know what their job is going to be when the patient arrives.
Okay, that's awesome, Bruce. Thank you. And in fact, this patient is rolling in. And for simplicity, I'll give you the EMS report and perhaps go through the primary survey. And then you can talk about how your approach to the next interventions in resuscitation. So the EMS report is that there is a driver of an ATV, and he was going at quite moderate speed downhill and lost control when it rolled over, and he was actually thrown about 15 feet and landed on his right side. So it's unclear whether there was a loss of consciousness, but he obviously is complaining of severe pain to his chest and pelvis. The initial vitals essentially have unchanged. He's tachycardic, tachypneic, and hypotensive. So when he arrives in your trauma bay and you've been prepared, you do your first primary survey and assess the airway, and the airway is intact. He's moaning, but he is a bit confused. Can't really give you much of a story. He's complaining mostly of pain. His breathing is definitely labored. He is tachypneic. He has decreased air entry to his right side. He's got bruising and tenderness and crepitus on that right chest wall. The C is an issue. He's cool. He's peripherally shut down. He's tachycardic and tachypneic and looking pale. He's tender to his abdomen on the right side. And you palpate the pelvis, and it is very tender and it seems unstable. The right leg is slightly externally rotated. He is, as mentioned, a GCS of 12. His eyes are closed, they open to voice. He is confused, and he will, his best motor response, he will respond to pain, but his lower extremities are very painful, so he's not moving them very much. So Bruce, he's now in your trauma bay. You've been prepared with some extra help. Can you go through your priorities, your resuscitation? Obviously challenging when you only have a few hands there. Lots going on.
You bet. So I'm not going to assume numbers of people that we have, because as I say, it varies. But this is a patient that certainly sounds very sick. It's a good thing that Sarah had them drop some ketamine and phenylephrine, et cetera, so that we have those things ready. Often, as the paramedics come in and they put the patient on the stretcher, some simultaneous things are happening. We do a lot of sim work, so the nurses know that their job is to get large bore IVs in, get oxygen on, get them on a monitor. So they would be doing that. The oxygen would just be nasal prongs, 5 or 6 liters per minute, and a non-rebreather mask. So those things would be pretty automatic. The paramedics are often asked to stay and help if they can, if they don't have another call, because that's 2 extra bodies, which is fantastic. And I often have one paramedic assist at the airway with myself or with the second doctor, so that the other doctor is free to do other things. And they'll be useful for a log roll later on whenever we decide to do that. Anyway, in this case, just from what you've told us, it's pretty obvious that it seems like they're in hemorrhagic shock, with blunt right chest trauma, definitely pelvis trauma. It sounds like extending to the right hip, and possibly abdominal trauma as well. They could have a head injury, or they could just be hypoxic. They could have a C-spine injury, even though there's no neurologic deficits. So we've got some major sources of bleeding in the chest, the right chest, the pelvis for sure, and perhaps the abdomen. So coincident with the nurses doing their thing, I guess the next, I should say, I usually try and get to the head of the bed really quickly, whether I'm the trauma team leader or the airway doc, and I say, hi, so-and-so, even if this guy is GCS 12, and I will just say, I'll try and lock eyes with them, and I'll try and say, we are going to take care of you. I know you're in pain and you're scared. We're going to take care of you. And I think it's really important to do that regardless of the situation. And then, as in this case, I'm going to be telling him, I might even ask about meds and allergies. I mean, if he's talking at all, because he might be able to actually give us some information. And sometimes when they come in extreme pain, if you just lock eyes with them and get them to focus again, you can actually get amazing amounts of information that other people weren't able to, because they've just had this incredibly traumatic experience, you know, in the ATV or whatever else, and with their transport. And so they're very often afraid. In his case, he's unstable, he's in hemorrhagic shock. So the nurses are being told to draw the rainbow of blood, just blood tests, to get lab, to get O positive packed red cells going, to give TXA a gram if it hasn't already been given. And I'm going to tell him that I'm going to give him some medicine. This is the kind of guy that it sounds like I'd probably give some medicine to. It's probably going to be ketamine to be safe. It's probably going to make him feel weird. So I'd tell him, we're going to give you some medicine, help with your pain. You're going to feel some needle pokes from intravenous's going in. You're going to feel some pressure and some sting on the right side of your chest as we place a chest tube. And just tell him what we're going to do really quickly, and give him something for pain. So I'd probably give him 25 to 50 milligrams of ketamine pretty quickly, and get the chest. And then I or the second doc, since the airway is stable with the paramedic, we'd be putting a chest tube in and see what we get. And
yeah, so actually, you actually do I forgot to say that you did your bedside ultrasound.
Sorry.
And your EFAST does show this. So there's no lung slide on the right, good lung slide on the left. So consistent with the pneumothorax. And you have a look at the belly, and in the right upper quadrant, there's a bit of fluid in the right upper quadrant. There's some fluid in the pelvis as well, and there's no pericardial effusion.
And the EFAST is done along with the primary survey by whichever doctor is available to do it. So again, in this case, it would be the first intervention while the nurses are working at what they're doing would be to place a chest tube and see what the result was.
So you placed a chest tube, and Bruce, do you what size of chest tube would you use?
Yeah, so I mean, anything above 28 has a trocar, doesn't really matter. This is going to be a large bore chest tube. At least it's probably going to be a 36, but at least a 32. I'm assuming this is a pretty normal sized gentleman, like 70 or 80 kilos or something like that. So it would be a large bore right-sided chest tube in the fourth or fifth intercostal space. And, yeah.
Great. So yeah, we can talk about chest tube sizes, but yeah, let's say you get a gush of air and there's 200 cc's of blood that comes out, and that seems to slow down. It does improve his respiratory status.
So that is good. And then I guess the secondary that we'd want to try and stabilize while we're getting blood going would be it appears that the pelvis could be unstable and a source of bleeding as well. So we try and get that sheet binder that we place down, try and get that secure and see what we feel when we do that. And ask X-ray that we will be wanting eventually to get a portable chest and pelvis film. Okay. So what do we feel when we tie the pelvic sheet?
Yeah, so there you do put on and I like to call it a trochanteric binder rather than a pelvic binder, just reminding everyone that the center of the pelvic binder is over the greater trochanters. And you pull with your sheet, and you've given some blood, and he seems to be a transient responder. His blood pressure is improving. His blood pressure is now 110 systolic, and his heart rate's about 100, and his SATs are improving. And
do we feel crepitus when we?
Yes, you did. There was crepitus and a lot of pain, and it felt unstable when you first examined.
So we'd be careful with that. You know, we wouldn't keep pulling, but we'd certainly want. Yeah, we would just be aware of that and just get it nice and snug, I guess, is the thing.
That's awesome, Bruce. So we're giving empiric blood. You've given TXA. You've put on a pelvic binder. You've put in a chest tube. You've already alluded to the fact that this guy is going to need transport out. And Sarah, maybe I'll have you take over this resuscitation now. And you have started this resuscitation, but clearly they need transport. And again, this is very specific to your region. how they're going to be transferred, what source, what phone number you call, etc. Then you typically, most trauma systems have a sending, receiving physician conversation to make transport decisions and sometimes some management decisions. Sarah, what would your next step be? And then I guess the other question with transport is, you've had B and C, what about A? Who do you intubate? Do you need to intubate? And how do you make those decisions?
Absolutely. I always say that medicine is a team sport, trauma especially so. And I think in rural and remote medicine, you may only have a few sets of eyes and brains. So calling early, asking questions, and having like no sense of shame, I think is the best thing that I can do for my patient. So I'm going to be asking to speak with the receiving physician to say, listen, first of all, where am I going? Because in many of the places I work, there's often more than one, there's two options. I'm going to run down what I've done. What have I forgotten? Do they have any feedback? Sometimes they'll suggest things that I just simply don't have, and I'll let them know that, and go from there. In some places where I work, when I'm speaking with this physician, I have the opportunity to say, the team that's flying in, can they bring these additional resources? So for instance, if I think I need blood, if I want some fibrinogen, is there any way that the team can bring that in with them? Sometimes it's a yes, sometimes it's a no. And then after going through the patient, sort of how they presented, what their current vitals are, having an up-to-date set of vitals makes everyone very happy. The next discussion, and I very much think it needs to be a discussion, is, am I intubating this person? In some places I work, we are literally bagging by hand for up to 4 to 6 hours. And that's not always in the patient's best interest. So if they are maintaining their airway well, we think they're at low risk of vomiting, we might keep them sort of breathing on their own for a longer period of time. And then when we have an ETA, we know that the plane is coming in or the helicopter, then closer to that time we'll intubate. If we anticipate a really terrible intubation and we have, like, my hands, a nurse and a cleaner, I might wait for the team so that there's another person there. But I'm also going to get the receiving physician's perspective. I find often they're a little bit more aggressive than I am, simply because they can't see the patient. So sometimes if you have the ability to video conference in people, that can help to reassure everyone and get a better sense of what's going on.
Yeah, great point, Sarah. And in fact, Andrew is your TTL on call that day. And so you put your call through, you're trying to arrange for transport. Transport is actually on their way. And you're going to speak with your trauma team leader at the Level 1 Trauma Center. So Sarah, do you want to share your case with Andrew?
Sure. Hi, Andrew. It's Sarah calling from wherever I happen to be that day. I have a 49-year-old gentleman who was involved in an ATV rollover. He presented to us as, tachycardic, a little bit hypotensive, systolic of 90, maintaining his own airway, GCS of 12. Came in via EMS, obvious right-sided injuries. He has what we believe to be a hemopneumothorax. There's a chest tube in place. His pelvis was not stable, so we've put a trochanteric binder on it. He has received TXA, ketamine. We have 2 units of blood that we can give him in the rapid infuser. And his current vitals are as follows. We are expecting the team in 35 minutes. What would you like in terms of, what would you like for us to do before we transport this person and to make sure he's ready for you?
Yeah, thanks, Sarah. Super thorough handover. And sounds like the patient's been well managed and ready now for to kind of be moved out of your center. I think, there's certainly not anything that I would change up to now, that's for sure, in terms of what's been done. I think what's interesting is that the team has decided to approach, and manage more definitively the hemorrhage through the pelvic binder or trochanteric binder, and then ultimately manage the breathing and potential for obstructive shock through placing the chest tube. And I think that's really great, because often, we're nudged towards managing that airway right away, just by the heuristic that we're so commonly, used to following: A, then B, then C. So I think this approach, I think, suits this patient, because there's no emergent need to intubate him. I think most of us would agree at some point he's going to need to be intubated, whether that happens at the sending or receiving institution. I think that, that's the conversation that Sarah and I can now discuss in terms of her resources and what our resources are, and ultimately the patient's clinical trajectory. What I'm hearing, I probably want to go ahead and intubate this patient prior to transport, if that is just too many variables that would be, that can't be controlled. And so to try and reduce or to improve the control of some of those variables, I'd advise on intubation. And part of that, I think, would be also, how do we approach the targets for this patient? It really doesn't sound, hemodynamic targets for this patient. And it doesn't sound like he's particularly head injured in a way that, he needs to be, that he's demonstrating signs of increased intracranial pressure or anything like that. So that reassures me that we can, maybe we don't have to be so aggressive with our blood pressure to try and get it too high, and we can tolerate a little lower blood pressure. So, but I'd kind of, continue the resuscitation to keep his blood pressure around systolic between 90 and 100, probably, particularly if they're going to go ahead and intubate. So, and I'd use a reduced dose of ketamine. I don't know, Sarah, would you plan on intubating him? Is that suitable to go before you to intubate, to transport?
Yeah, from my perspective, I would like to intubate this guy. I don't know when he last ate. We have a prolonged time to get him to any other place. We're looking at least an hour and a half. I don't know what he's going to look like 2 hours from now. So I think it is worthwhile to control what we can control, because trying to control that in a helicopter or a plane is not going to be fun.
That's a great conversation. So it sounds like you're going to go ahead and intubate, and the advice regarding perhaps a lower dose of an induction drug in someone who may be in hemorrhagic shock is a good one. And he is anatomically an easy airway, and you're actually able to intubate using RSI, and you get post intubation x-rays. He's got a chest tube, endotracheal tube. It's like multiple right-sided rib fractures with subcutaneous air, and probably a pulmonary contusion and or layering out of some blood. And his pelvic x-ray, pretty significant right-sided fractures with wide open book. So this guy is coming by air, and air is there, and you have you've tried to keep him warm. You're going to try to tighten that pelvic binder a little bit more, and you're going to continue with whatever blood products you have. And in your rural site, you only have PRBCs. That's a good point about whether ambulance can bring blood products, and I'm not sure in different sites across the country. In BC, they are able to bring packed red blood cells, but we don't yet have plasma or other products. It's coming from a pre-hospital standpoint. So Andrew, they're on their way. And actually there's just a couple of questions that I wondered. And one is just around the idea of that you had a chest tube put in, Bruce put in a chest tube. Let's say you have very few people, can you just do a finger thoracostomy? And wondered if anyone would like to answer that. And secondly, again, the question was regarding the use of EFAST, and that it doesn't necessarily rule out particularly intra-abdominal trauma. It just really is whether it's binary, is there free fluid or not, but that doesn't rule out trauma. And the last question is around permissive hypotension. And Andrew, you alluded a little bit about blood pressure targets. So who would like to answer around finger thoracostomy and chest tube? Yeah, Bruce.
Yeah, just to start off, because I put this large bore chest tube in, but the reality is, if the patient was an extremis and I was really concerned about attention, we probably would just do a finger thoracostomy on the right side, followed by a chest tube. And the chest tube would be whatever's handy. We wouldn't fuss about too much about the size. At 28, is really handy. 32, whatever happens to be handy, and what the doc is comfortable putting in. The point is just getting one in. A little bit larger might be better down the road. As far as so that we wouldn't have to place a second one, knowing that we were in. But so I wouldn't want to fuss too much about that with the size. I wouldn't. We do have needles. We do have 3 1/4 inch angiocaths to put in if we're concerned about tension. This patient's neck, the trachea was midline, but some of them in big guys just don't go all the way through. I think it's an idea not to put them in the second intercostal space, but to put them in the fourth inner space as well. If you just want to do that quickly to relieve a possible tension, because you'll have a better chance of getting in. And then of course the finger thoracostomy followed by the chest tube. As far as the EFAST, for us, we had an EFAST before we had a CT scan, and for us it was more of a rule in. For us, it was a rule in. If we saw free fluid, we could finally ask the EHS to take the patients more quickly to the city if we saw free fluid. Whereas if we just had blunt abdominal trauma without free fluid for sure, then it was hard to expedite their transfer, because they were always stable. Most of them were stable, and of course until they become unstable, and then they can destabilize very quickly. So the EFAS was very, very good at, if we had a positive, if it was binary positive for free fluid, boy, we could just call transport and say we've got bleeding in the belly and they've got to go now. And so that was very helpful. But we certainly didn't use it to rule out. It was never a rule out test for us, because we didn't trust ourselves to be able to rule out.
Great. Any other comments from Andrew or Chris on that?
I mean, there's so much going on in this case. My brain is starting to swell. My first question really is what do you chase the bears away with? But maybe we can come back to that later.
Air horn.
And also listen to this conversation. It occurs to me how much harder trauma is everywhere else except where Andrew and I work. So acknowledging the la land that we work in, and at the moment feeling pretty grateful I don't have to chase away any bears. Usually just orthopedic residents when they try and fiddle with the pelvis, but otherwise, I'm obviously, I guess, always deeply impressed with the work that gets done outside of a trauma center and a 15-member team, and that's true in this case as well. I agree with what's stated about ultrasound. I think that the confusion that comes up in point-of-care ultrasound really is twofold. It really should never be used to dictate decisions around transport or the necessity for further imaging, specifically CT. So a negative ultrasound really doesn't help you at all if you're trying to make a decision about whether the patient needs axial imaging, for example. And I think that's important because that decision links to whether or not a patient requires transport, especially if you're in a place that doesn't have axial imaging. So that's one potential pitfall with use of ultrasound. The second, I think, is that in recent years, I've come to rely more on point of care ultrasound for thoracic trauma than I do for abdominal trauma. It's relatively, it becomes a bit of a, Bruce is right. I mean, you got a positive FAST, you're essentially done, that patient needs to move. But from a bedside management point of view, I find it's much more commonly directing my care when I place the ultrasound probe on the chest and look at the heart, both for hemopneumothorax and for cardiac injuries. And the president's free fluid in the abdomen is sometimes a piece of the puzzle, but not something that I generally speaking act upon very quickly. And so one of the takeaways I think is really give a think to what we commonly call the FAST, which is 3 views of the abdomen and then a pericardial view. should really be considered an EFAST or just an extended point of care ultrasound with a specific focus on what you may or may not see in the chest. And also, it's going back a ways, but I really wanted to pick up one point that Bruce made about speaking to your patient, because this is one of those messages that translates, I think, in every setting, regardless of resource. The importance of going to the head of the bed, letting the patient know that you're there to look after them. This is one that I ripped off from an American colleague, and I wish I could remember who, but they say, do you have family here? And if the answer is no, we say, well, we're your family for the next few hours. And I think then the other little bit about, trying to make sense, trying to help with sense making for patients is to tell them what to expect. So everything that Bruce said is true about what's coming next. But then I say, I will come back. I mean, maybe not for this patient, they're going to get some ketamine and forget they're on planet Earth. But otherwise, I try and let them know I'm going to come back to you when we're done all of this work. I'm going to let you know what's going to happen next. That I find is a very powerful message to say, I haven't forgotten about you. We're gonna come back, and typically then at the end of the primary survey, when we're ready to go somewhere, I come back to the head of the bed and say, okay, here's where we are, and this is where we're going next. It bugs me to see a team of people stand around and speak about a patient. And we do this in trauma more than we never walk into a medical patient's room and stand around and just talk about them, or at least I don't find we do, but trauma, somehow that seems acceptable practice. So there was a lot of work to be done in humanizing these patients. And I think just having a conversation with them, as Bruce suggested, is important. On the medical side, chest tubes, I think, I used to love throwing in 36-inch chest tubes. It was like a favorite pastime. And as it turns out, you just don't have to. I agree, a finger thoracostomy in a pinch, and probably in this case, sometime before transport, as resources permit, placement of a tube thoracostomy would be beneficial. When we were planning this discussion, we talked about the importance of people like Andrew and I not monopolizing the time of people like Sarah and Bruce, who need to get back to the bedside. So another common utterance, if you find yourself on the receiving end of these phone calls, is to say, how can I help you get back to the bedside, and what do you need from me, as opposed to a few thousand questions about the patient's status that, frankly, I don't really need to know and can probably answer when the patient arrives. So I think it's important in acknowledging our role to help people like the both of you get back to the bedside, to keep doing the work that you're doing, and not monopolize your time by way of conversation.
Thank you, Chris. Those are all great points.
I was just going to comment on the Sarah started giving blood pack cells, because I think that's what they had at the site, and I think that it's pretty reasonable to accept that that's totally fine. That we worry about ratio-based resuscitation, and that should happen. That should be the goal, but that doesn't need to happen within the first 15 minutes. So it's totally feasible, or it might be feasible only to get pack cells, and that's great, because we'll then, when they arrive and if they need further blood products, we'll switch over to FFP and platelets as needed. So I think people do get a little bit stuck on 1-to-1 or 2-to-1, whatever it might be. I think that as long as that communication happens in the handover, here's what we've given, or that it's readily available in the documentation, then we'll balance it out when they arrive, if they're being transferred.
We did skirt the question about targets. I can try and give a 30-second answer on that. If we're having a conversation of what to shoot for, when you should get more blood, and what you should aim for, I'm typically much less interested in hard hemodynamic targets as I am in evidence of adequate end organ perfusion. So if the patient has a good radial pulse, if they don't feel peripherally shut down, if they're mentating well, and if you really are a numbers person, if they have a systolic better than 70 outside of a catastrophic head injury, I'm usually pretty happy with that. And I think it should be worth noting, this is a shocky patient. Hazel, you described them as a transient responder. I don't know if that meant their blood pressure came back down again, but certainly if they're a non-responder or a transient responder, you should make the assumption that they're actively bleeding, and the actively bleeding patient is different than the shocky patient. The two aren't totally synonymous. And so if your presumption is that this patient is actively bleeding, and I think it's safe to say that they are, then again, really, I'm feeling peripheral and central pulses. I'm looking at their ability to mentate. I'm feeling their extremities. And even if I think they're bleeding, if they're checking all those boxes, I'll certainly have blood and blood products on hand if I can, but I won't actively give volume unless those things are falling off.
I'll push back a little bit on that, Chris. I'd probably give.
Of course you will. That's because you're wrong.
I probably won't. It's hard to tolerate a systolic of 70, even and I know there's recommendations out there that would suggest that, but I personally, I find it hard to keep them at that. So personally, I'd probably keep this guy in and around 90. I just think it's, he's going to be transported, and even when he arrives here, moving people around, it's hard to do. But, and I also just did that simply to disagree with you.
What else? Welcome to my life.
Nothing better than that.
I would add. I can't argue too strenuously. You're right. The guidelines are not clear, and I think starting off the conversation by saying again, I'm less impressed really by what the actual number is. If that patient was showing signs of end organ hypoperfusion, I think that's would typically be my trigger, and that might be at a systolic of 90, maybe a systolic of 70. But hard to disagree with you there, Andrew.
Bruce,
Hazel, I would just want to mention the chest tube. That one of the benefits for us of the chest tube is just measuring how much they're bleeding from the chest, and we do have an auto transfuser that we have used in the past, and that has helped people. So that's
Great
just
point.
something that's
Yes.
open. Yeah.
So if this person had a massive hemothorax with ongoing bleeding, and you may be in a rural site that has limited blood resources, this is a great way of transfusing back the patient's own warmed cross-matched blood, which is if they've got a big hemothorax, you and then attach to an auto transfuser and can then transfuse back their blood. So that's a great point, Bruce. And
I'm putting that on my Christmas list.
yeah. The last question was just regarding the dosing of ketamine, and you already mentioned decreasing the dose of ketamine in hypotensive patients, but please don't underdose the dose of your paralytic. So something like rocuronium still, you don't want an under paralyzed patient. So don't scale back. Give full paralytic dose in your RSI. So they are now, or have arrived now, Andrew. So Andrew, you are the TTL, and Chris is the emergency physician working at St. Mike's, receiving this guy. When I said transient responder, meaning started to improve, but actually in transport it's getting worse again, and is arriving cool and shocky into your department, has had 3 units of PRBC, 1 gram of TXA, not a lot of crystalloid. So
I think, Hazel, I think Sarah had a comment.
yes.
One comment I just wanted to squeeze in there is to advocate for pain control. I think there's some good work out of Orange in Ontario that shows that people who are being transported, especially long ways, often miss out on that key part. And I think all of us, if we were paralyzed and intubated, would definitely want adequate pain control on board.
Fantastic point.
And if you're looking for an additional resource on that, Andrew and I put a chapter in Ruben Strayer's free online work on pain control, the emergency department, and it was a chapter specifically on pain in the polytrauma patient. I agree with you completely, Sarah. We either underdose or just don't dose pain medication because we're worried about the hemodynamic implications. A pain should never be a oppressor, and certainly if you're worried about all other things, ketamine makes a pretty good alternative for almost everything from sedation to post-intubation sedation to analgesia.
Okay, so Andrew, they've arrived in your department. As I mentioned, they're clearly ongoing shock symptoms. Can you go through your resuscitation?
Yeah, great. I mean, a couple of things. We'll obviously we'd get some info ahead of time, and we would brief our team, just like you heard the other team be briefed with whatever information that they have. And we're hearing already that this patient's going to need ongoing resuscitation, and likely this would be a prompt for us to activate our MHP, our massive hemorrhage protocol, with the goal of being able to start to ensure that there's a balanced resuscitation occurring in terms of the blood products. So that would be really key as the communication to our team that's going to be a priority. And when that kind of happens, so I can, Chris and I will script that part out for our team for the first 5-10 minutes so that can happen, automatically. And then we can figure out about next steps for this patient, because there's not many people in the room that are thinking about the next steps for the patient. And really that does fall often on the team leader to think about, are they going to the OR? Are they going to the angio suite? Is it going to, is this a combination? They're going to need to go to a hybrid spot or whatnot. Or is CT a viable option? And so we'll start the resuscitation, and it's pretty clear. We try and make it really clear to our team about what we expect in terms of balancing products. If they've gotten 4 or 5 units of packed cells, then I'll ask our nurses to just give, once we have the FFP at the bedside, then we'll go, I'll say, give the next 3 units of FFP. We'll continue to reassess whether the patient needs it, but if they do, that's what the products are going to be. So it sort of automates that. And we heard that the 1 gram of TXA was in already. I think it's pretty reasonable now, and the provincial guidelines going to be pushing provincial guidelines in Ontario will be pushing 2 grams. And so if one's given already, we'll just top that up with a second, and it won't be as an infusion. And honestly, for the rural sites, sometimes when I get the call from the sending institution, I'll just say, just give the second one now, give the 2nd gram now, and then it's done.
And the issue of who needs a massive hemorrhage protocol is a tricky one. The traditional definitions simply don't really suit the clinical need to make a decision at the bedside. You've heard Andrew choose his words carefully in saying massive hemorrhage protocol. That's because phrases like massive transfusion protocol come with all sorts of baggage, like 10 units in 24 hours and things that don't really apply at the time. If you are in a situation where you're trying to make a decision, we've Andrew and I both spoken about the concept of resuscitation intensity in the past, which means if you're up around 3 or 4 units of anything really, of any blood product or any element of volume resuscitation, and you haven't kind of clued in yet that you might sort of be nudging towards a massively bleeding patient, that should be your trigger. So, I mean, Bruce and Sarah have already given us a good enough story to get the fact that this patient is bleeding. But it's not this patient that's going to fool you. It's going to be the elderly patient with the slowly trending vital signs that sort of might escape you. And so you may just give a unit and give the other unit. Now you're up around 3 or 4 units. That should be your trigger to say, the intensity here is such that we're likely to require a massive hemorrhage protocol. And if you have one, it's a good time to switch it on. And the other thing in subtle presentations that can help you is the shock index, which is a super simple calculation of heart rate over systolic blood pressure. Again, this patient is not going to fool anyone as far as their presentation for shock. But very young patients with wonderful young patient physiology and very old patients with very weird and medicated physiology will trip you up. And so for me, it's that concept of resuscitation intensity plus a bedside parameter that's objective, like the shock index, maybe their end tidal if they're vented, that will trigger me to head in that direction.
And so if we're continuing it on, I think we'll use we'll continue the resuscitation with packed cells and FFP, and we'll use platelets when needed, because usually you can get a platelet level back, and if they're not deplete in those, then often we won't administer that unless they're sort of under 100, or there's another, maybe there's an antiplatelet on board. But in this case, unless that's happening, then we'll probably hold off on the platelets. We'll focus on getting the TXA in, and then once we've hit 3 or 4 units, I kind of use 3 or 4 units in general as my cue to reset. And so when 3 or 4 units happens, I'm going to give a gram of calcium. When 3 or 4 units happens, I'm going to think about, if I haven't called for MHP, I'm going to, and I use that as my reset point to kind of establish that, okay, this patient is a bit sicker than what we thought. And the one final thing I think that we underappreciate in these patients is the impact of temperature on their survival. So if they're hypothermic, we really, do need to get them warm, and it's not really super helpful to warm up the room, but rather, the warmer fluids coming through the level 1, keeping them warm with sort of warm blankets. Those are more effective, and obviously if you intubated them, then warm humidified air.
And as I'm no doubt by this point bugging Andrew to let me do a Roboa in this patient, but he's being stubborn and not letting me. So leaving that aside, I think it's important not to miss the simple stuff too. So I think it's worth remembering this patient was just transported and placed into a helicopter and put out of a helicopter, and then in our shop taken down an elevator. And my script when patients arrive like that is not quite, along the lines of a primary survey. I think about clearing systems from head to toe. So when a patient comes in like that vented and not giving me a lot of information, except maybe really by way of their vital signs, I start at the head, physically start at the head and start at the endotracheal tube and work my way down and look at the neck, pull off the collar, make sure that we're not overlooking something there. They have a chest tube, but chest tubes move. So what's the depth of the chest tube and is it functioning well? I'll look at the pleurovac attached to that to make sure it's functioning. Simple stuff like that. The binder, is it in the right position? Does it look tightened enough? And my approach is very anatomic. It literally goes from head to toe in that primary survey, which I find works a little bit better because this is a patient who's come by way of transport. They have a story. They've received care and resuscitation. You're not really starting at the primary survey necessarily. So you have a bit of information now. You're just walking down from top to bottom. And again, if you've got an unexplained hypertensive patient that you know is bleeding, it's really easy to latch onto that and miss the fact that the chest tube is kinked or has come out of position and you've got tension physiology. So just a reminder there to go a little bit back to basics and make sure that whatever your process is, that you're systematic about it.
Excellent points. And that is, we definitely hear stories of when there's transfers and equipment either fails, your right chest tubes can kink, and then they can get tension. Their endotracheal tubes can be dislodged, and we forget about that. So those are all great points. Andrew, you were talking about the balanced resuscitation, and you mentioned plasma platelets, packed red blood cells, calcium. At what point would you add fibrinogen? And I see that a lot of sites are now moving away from cryo and using fibrinogen concentrate.
Yeah, and we certainly are. We use it based on numbers. So once you hit sort of less than, depending on your site, probably 1.5 is an acceptable target. 2 in European countries, but definitely if it's less than 1, then you're probably behind. So, but we don't do it empirically. It usually comes down with our third cooler. So, you're 40 minutes into your resuscitation by then. So I don't think it needs to be done immediately. But if you're in a place that does not have plasma, and then you certainly could use, and just on a side note, you could use PCC, particularly if you think the patient is going to be there for a while. So that's a suitable alternative, not well studied, though that study is going to be happening soon.
There's a question around indication creep for TXA. I know that everyone is familiar with the CRUSH-2 study, and what they're saying is that EHS is giving TXA for hemodynamically stable patients. What do you think? Is that a battle that we shouldn't pick?
Yeah, I mean, we can walk into the TXA forest if you really want to, but I also notice we have about 5 minutes left in the conversation. Yeah. I think my indications really are less than 3 hours in a patient who I think might be bleeding. They don't have to be stable or unstable. The earlier you give it, there is certainly a dose response curve predicated on time. So if you give that medication, if Sarah and Bruce give it in the first hour, that's going to be much more beneficial than 2 hours later when I have the opportunity to give it. And a question I got asked once, which I'd never thought of, and it applies to sort of the rural and remote environments in particular, is should I give TXA if I don't even have blood? And from my perspective, the answer is yes. If you have TXA and you don't have blood, again, you don't have to be actively transfusing the patient. You just have to believe that you think that might be what they require. And so in my mind, I'm actually okay with the TXA creep because in that particular population, I'll leave the head injured population aside. Maybe from my perspective, there's fairly broad-based gains to giving that medication early and often in patients you think might be bleeding.
Yeah, there was a question around any pearls for remote settings that don't have blood products in that transient or non-responder to that initial crystalloid bolus. And
Andrew, do you want to touch on Andrew was part of a writing group that wrote some guidelines specifically for that, and I know fibrinogen and concentrate is one of them. Plasma, another. I don't recall.
I think Sarah's going to say. Sarah, go ahead.
I was just going to say, I think the number one thing, as mentioned before, is to give what you have early, right? So if you've got TXA, get that on board early. If you happen to have fibrinogen and you have nothing else, start giving these things early because you need to stop it so that you don't need it later, right? In terms of blood. So I just say be on top of it. I have no problem with TXA creep.
The one that hasn't come up is 4-factor prothrombin complex concentrate. And Andrew, you can speak more learnedly this than I can, but in a scenario where you don't have FFP, that might be a reasonable, if not terribly well studied alternate.
Yeah, for sure. PCC is definitely reasonable to give in these patients when you don't have FFP. Yeah.
And another question.
Can I just make the point, Hazel, that we, Dr. Andrew Shee, Vancouver General Hospital, has come out with a really, really good rural massive transfusion protocol that we can follow. It's just come out. It's very, very useful, and rural sites can use it in a stepwise fashion. And then we often talk to the hematopathologist on call in terms of what we should be giving, depending on what we have, depending on the clinical situation. So it's really useful.
That's a great point. And what we could do is there's a few links that people are asking for. One is for that pain control article, Chris, if what we could do in our notes later on is to put that in, as well as we can put references to at least our rural hemorrhage protocol that was created for our sites. We're getting towards the end here. And I wondered if we could, it's been great discussion. And of course, this sick guy has ongoing hemodynamic instability, and then you make decisions, where do they go? And probably in this situation, when they're ongoing hemodynamic instability, would be to the OR. But again, that's always the question, at what point are they stable enough to go to IVR first or to CT before the OR? But that's something that you would do collaboratively with your surgeons. I wondered if we could do some wrap-up take-home pearls from each of you. Thank you so much for the discussions. Bruce, any pearls from your point of view in that resuscitation of the multi-trauma, particularly hemorrhagic patient? It is the #1 cause of preventable death and trauma, so that's why we put a lot of emphasis on this today. But Bruce, any pearls?
My only pearls are if you can arrange trauma updates with your regional trauma people, if they can come out to your site and have a trauma day with you, like Hazel does, and where you use your own staff and your own equipment, that is incredibly advantageous, rather than going to an ATLS course or a course in the city. And then sim training is just, we've just found that so useful the last year or so that Dr. Garreau started that for us. So those are my pearls.
Excellent. Sarah?
Through this process, I found out that one of the places I work has stocked fibrinogen for over a year. Not a single practicing physician knew that we had it, and it hasn't been used. So, having open relationships with the lab and maybe you have a rad that visits on site, and finding out what they can do in a pinch and what exists or what's coming down the pipeline, I think can help make everyone better.
Awesome. Andrew?
Yeah, I think one of the kind of key things that I've been adopting more recently is having an endpoint and a target for my resuscitations. So not just blindly administering whatever it might be, medication or blood products, but actually then a priori setting that step, whether it be based on mentation, whether it be based on a blood pressure cutoff, whether it be a combination, whether I have to get in a fight with Chris about that, I don't know. But some target before I get to that point, so that I know, okay, once they're mentating again and I'm happy with the blood pressure to move them, then I'm going to stop that resuscitation, and being very mindful of those targets.
Great. And Chris?
Yeah, I agree. I mean, if you're just chasing stability, Hazel, you mentioned the notion of stable versus unstable. That become a very recursive discussion, and you look at your watch, and suddenly you've been in the trauma room for 2 hours trying to achieve stability that's just not coming. I agree, having sort of a sense of targets, and maybe not subscribing too doggedly to the notion of set numbers in your hemodynamic targets. Every patient's going to respond a bit differently. Simon Carley talks about the notion of flying your patient a little bit. If your patient's a little bit tenuous and you're going to give an induction agent, try 10 to 20 milligrams of ketamine, see how they respond. You can always give 10 to 20 more. Challenge them with a volume challenge with blood products and see how they respond. feel your patients out a little bit, because everyone is going to be a little bit different. And that, I think, is where you get away from these notions, the notion of hard targets, which apply very poorly to the individual patient, and will allow you to sort of tailor your resuscitation along with the targets that everyone was talking about, to the patient in front of you.
Excellent. And again, as to Bruce's point, my plea is also to continue with simulation training in all of your sites, wherever you may be. It's team training in a big site or rural with your small center, and really understanding what do you have. Do you actually have fibrinogen? Do you actually have certain equipment? So a real push to sim training for team training for major trauma resuscitation.
And reach out for that too. We have, as many other hospitals do, rural trauma outreach programs. So exactly that. We don't tend to show up and tell sites how they ought to run their traumas, but we try and listen and understand, and then work with the resources and the local expertise.
Exactly. Thank you. That's awesome. I want to thank my speakers. Thank you so much. And thank you to all for joining. Again, thank you to CAEP for all their work and organization. Please fill out evaluations and you will get a CME form apparently within a day. And I just want to say thank you to this amazing emergency medicine community. I am so proud and grateful to be part. You are my people, and what an amazing year, and what amazing things we've done and stepped up in this year of crisis. And I wish you all a very safe and healthy holidays, and may we see light in 2021. Take care.
Keep well. Stay safe, everyone.
Thank you.